The ability to move contributes to our self-worth and well-being. Mobility is necessary for all aspects of our life. A decline in the client's mobility can result in health problems. Clients with acute and chronic illness, injuries, or surgery, they're going to experience a period of immobilization. Factors contributing to their immobility includes things like the length of stay, severity of the illness, their emotional status, and physical conditions. Okay, so we need to be aware of a lot of the things that can happen as a result of immobility. So if we think back years and years and years ago, humans had to hunt and gather food. Survival depended on them being active. Well, today we're not as active. We have grocery stores and we spend a lot of time sitting at our desks. We have a sedentary lifestyle. So we're not moving as much as our ancestors did. Your goal in nursing is to maintain their range of motions in their joints and posture. Now, injury and disease can lead to many alterations in their function. So think about any disease that affects the muscles or musculoskeletal function is going to impair muscle development. So things like muscular dystrophy, when we have atrophy of the muscles. Any damage to our central nervous system is going to affect our body alignment, balance, and mobility. And that damage can come from maybe a head trauma, stroke, meningitis. If for some reason our cerebellum was damaged, we might start to have problems with motor and balance. So think about people that have a right-sided cerebrovascular accident, CVA or stroke. They have left-sided weakness. And if you had a left-sided CVA, you tend to have a right-sided weakness. Trauma to the spinal cord affects any voluntary control below that level of trauma. So regardless of where the spinal cord is affected, down below that area, it is going to cause them to lose voluntary control. And we also know that sometimes we have direct trauma to our musculoskeletal area. We have bruises, contusions, sprains, or fractures. And all of these could cause a muscle atrophy as well. So some definitions here we want to look at. Body mechanics is the way we move our body. Body alignment is our posture. With good posture, our body is able to function normally. It has less stress, less fatigue on our bodies. Balance, the center of gravity is below your umbilicus or umbilicus at the top of your pelvis. Your feet stand there as your base of support, and the lower your center of gravity, the easier it's going to be for you to keep your balance. Coordination, your cerebellum is the one part of your brain that controls your movements. And joint mobility, this is what allows us to sit, stand, bend, walk, perform different activities, perform range of motion. Now here I've put some pictures just to kind of show you some different types of musculoskeletal issues. So if you look at the very far left, that is foot drop. Foot drop can occur very fast. You might have someone who's in bed for a few days and all of a sudden their feet drop because that's kind of the normal way that they're laying. They just kind of relax them. Once we have that, it can be very difficult for them to walk normally again. What's happened here is those muscles have atrophied, they've kind of drawn up, and so they are not as bendable, they're not as long as what they were. Up there at the top, the picture there of the x-ray, that shows some hip dysplasia, where the hip can kind of pop out of socket. Below that shows kyphosis. Kyphosis is that hump on the back. You can have an excessive lump on the lower back, and we call that lordosis. Scoliosis is the picture of the child there. You'll see that their shoulders will be uneven because their spine has a curvature to it. So their hips will usually be uneven. They might have one leg that's a little bit longer than the other one. And again, there's varying degrees of that. Down there at the bottom, the baby picture is a baby with clubfoot. And usually if we have someone who is born with club feet, the doctors put them in casts and they monitor them very, very closely to try to get those feet to straighten. Now, your client can experience mobility and immobility in degrees. Think of mobility as a continuum that we can move in and out of a mobile state. Now, again, remember, the longer we have somebody immobile, the more pronounced the consequences of immobility will be. So think about this. Each day of immobility or bed rest that we have in the older adult, for each day, it takes them 3 days to get back to their full functioning status. Well, then why would we ever want to put somebody on bed rest? Well, sometimes they need that to reduce their activity and oxygen needs for their body. Maybe it's to reduce pain, to allow the ill client to rest so their body can heal. If they have exhaustion, maybe some uninterrupted sleep there. Musculoskeletal deconditionings and lack of activity can result in a series of symptoms that we call the hazards of immobility. So if we have a client that we're getting up for the first time in a while, we want to get a baseline of them laying down of their blood pressure, get a blood pressure of them lying down, and then we can set them up and let them sit there for a little bit, make sure they're not dizzy. If they're still dizzy, we can begin to look at them for orthostatic hypotension. We have 3 different types of muscles. First, we have cardiac muscle. Cardiac muscle only in the heart. Very easy to remember that one. We have smooth muscle, and this functions involuntarily. We cannot control this type of muscle movement. And then we have skeletal muscles. And the skeletal muscles are attached to our skeleton by tendons, and we can move these voluntarily. Take a moment and review some of these types of bones. We have the long bones. Those are going to be things like our humerus bone. A flat bone, when you think of a flat bone, think of maybe your scapula. Short bone, we might have our heel. Mixed bone would be maybe our vertebrae. Our bones are constantly remodeling each other. We get bones that some of the cells break away and they die, but it's constantly being replaced with new bone. When our mass of bone is decreased and our structural integrity is impaired, that outer portion of our bone becomes more porous and thinner. That's going to cause our bone to become weak and makes us more prone to fractures. This does lead to osteoporosis. Osteoporosis affects about 1 in 3 women over the age of 50. Again, more common in women, more common in Caucasian women as well. In fact, women are more likely to have a hip fracture caused by osteoporosis than getting some type of cancer. Now, this osteoporosis is usually silent and it progresses for decades until we have a fracture. Okay, women that have menopausal women that take estrogen, sometimes that helps to slow down some of that bone loss. So again, the risk factors here, if you have family history, if you're Caucasian again, the older you get, the more at risk you are. Female, small stature, if you're fair-skinned, thin build, early menopause, late menarche, or you start having your period later. If you don't have a baby, being obese, lack of taking in vitamin D and calcium, too much protein, too much caffeine, anorexia, a sedentary lifestyle, excessive smoking or alcohol consumption, those with rheumatoid arthritis, spinal cord injuries. So there's a lot of different risk factors that play into that. So for treatment of this, we can give them estrogen or progesterone therapy. We can also give them medications to increase their calcium. But the best thing to do for them is to get them up and get them walking. We have to bear weight on our bones to get them stronger. Limiting our mobility can cause loss of endurance, strength, and muscle mass, can decrease your stability. Okay, so to prevent, we want to keep people moving. So we always say in healthcare, if that person can do something for themselves, we want them to do it. We don't want to take over that job because we can be causing damage to some of their muscles. I mentioned atrophy. Atrophy is when that muscle gets really skinny. So think about if you've ever like broken maybe your leg or something and you've had a cast, and when they take that cast off, your leg looks really skinny. That's because that muscle has atrophied because it has not been used. Another definition we want to look at is sarcopenia. Sarco meaning muscle, and then penia meaning loss or small amount. So this is when we have a loss of lean muscle mass. Sometimes it's lost because we have protein breaking down. So these type of people, when they have increased activity, they get fatigued, their muscles start to atrophy, they don't have the endurance they need to as well. Plus, this also causes some joint instability, so now we're at risk for falls. Immobility causes, again, the joints to become stiff. The strongest muscles will pull the joints in their direction, causing contractures. So immobility can lead to joint contractures. This is an abnormal fixation of a joint. Okay, those muscle fibers shorten together, and that causes the contractures. That joint cannot obtain full range of motion. Now, we have seen people that will almost be in a fetal position, and there is no way that we can move them. They are stuck, frozen. If we tried to move those extremities and we put too much strength on it, we would break their bones, okay? So it's very important that we do everything we can, do some passive range of motion on these people, get them up and moving if they're able, because we don't want contractures to occur. Contractures can form after only 8 hours of immobility in an older adult. So if you'll look down here on this picture here is a lady that looks like she has some contracture of her hands there. And then down there in the right corner of the paper, it shows you the blue piece that they've got in the hand to kind of prevent that contracture from getting worse. So you might see, if you're in long-term care, you might see where they take a washcloth and roll it up and put it in their hand so they can hold on to it. Or you might see something like this. And what they're trying to do is prevent that contracture from getting any worse, or preventing a contracture in general. I mentioned foot drop earlier. Here's another picture of foot drop. They're not going to be able to lift their toes up off the ground, so that ankle's not going to move like it should. So to prevent this, we want to do, again, some range of motion. We have various splints. We have foot boards, high top tennis shoes, anything like that that we can use to keep those feet in a neutral position while they are in bed. We want to use those to prevent this from happening. All right, so now we're going to look at some of the effects of prolonged immobility. Prolonged immobility or prolonged bed rest increases our heart's workload. So when I increase my heart workload, I need an increase in oxygen demand. Okay. Another thing we worry about is orthostatic hypotension. And we've talked about this before, but this is a drop in their blood pressure when they're moving positions of 15 points or more, because what's happening is all that blood is pooling in the lower extremities. Another thing they can get is a thrombus, a DVT, a PE. That can occur because that blood's just sitting there stagnant, especially in their legs, their lower legs specifically, and it's sitting there, and it can just go ahead and have a clot. If part of that clot breaks loose and goes to my heart, I will have a pulmonary embolism or a PE. And we said that our heart is made of muscle. We have special cardiac muscle, and if my heart has atrophied, then I do not have good cardiac condition, right? I'm going to have to do some things like walk and try to use maybe a treadmill and try to get some activity to get my heart reconditioned. So some things that we would want to do to treat this, If they do have issues, if they're getting up for the first time, make sure we're moving them slowly. We can also increase or raise the head of the bed while they're in bed. We do compression stockings, sequential devices. You see those on their legs in the hospital, and they squeeze up and release and squeeze up and release. And that's to kind of help to keep some blood moving while they're immobile and to prevent a blood clot from forming. We can also do some flexion and extension of their ankles, move their feet in a circular motion, have them squeeze their glutes together, give them anticoagulants. If we're worried about them developing a blood clot because of their immobility, we can certainly do that. And we also want to increase fluids. Anytime we have someone on bed rest, unless it's contraindicated, we would like to increase their fluids. Respiratory, the two main problems that we worry about are atelectasis and pneumonia, and these could lead to lung collapse. So what happens is if I'm not mobile, I get the buildup of secretions in my airways. So atelectasis is the collapse of part or all of the lung. It blocks the air passages, the bronchus and bronchioles, or it can put pressure on a lung. So people that have been under anesthesia, again, prolonged bed rest, if I'm not breathing deep enough, that can cause mucus to plug my airway, and I can develop atelectasis. We want people taking good deep breaths. We want good gas exchange in the lower portions of their lungs to prevent things like that from happening. Pneumonia. If you look at the x-ray picture on this slide, you'll see that white opacity. That is a pneumonia that is there. So to prevent pneumonia from occurring, we'll give them in the hospital the incentive spirometer. They don't like it, but they have to do it. Remind them to do some deep breathing exercise, elevate the head of their bed, and of course we want to turn and reposition them every 2 hours. And when we do that, let's have them take some deep breaths and cough if they can. So when we are immobile, we usually have a decrease in our metabolic rate, and that's going to cause some metabolic disruptions. Our appetite is usually decreased. Our body excretes more nitrogen than it ingests, so that causes us to have a negative nitrogen balance. So you might see this person have weight loss, decreased muscle mass, and weakness. Probably the biggest thing that we worry about when someone is inactive is constipation. Constipation, huge in the older adult. GERD, also gastroesophageal reflux disease. If you're laying flat on your back, that food that you do eat is going to come up into your esophagus and irritate. So to prevent it or to treat it, malnutrition, we want to put them on a high protein diet, give them nutrient dense foods. If they're having constipation, we want to increase their fluid, increase their fiber. We may give them some stool softeners. And of course for GERD, we can give them medications, but we can also just increase the head of the bed and see if that helps them some. When they get up and get moving, that peristalsis is going to start again in their stomach, and that should help with their constipation. For the kidneys, calcium is lost from our bones when we have immobility. So what happens is our blood says, hey, I need calcium, and it pulls it from the bones. And if our kidneys aren't working right, it can cause us to develop either too much calcium in our blood, and the blood will also pull the calcium from our bones. So if I'm immobile, my body is pulling calcium from my bones, eventually I'm going to have brittle bones. The other thing that we worry about is urinary retention. We use gravity to help us to know that we need to use the bathroom. It helps with the bladder, helps with filling that renal pelvis. So if we're not up and moving, if we're staying in one position, we can have some urinary retention because our body doesn't feel that it needs to have an elimination time. Also, with all the calcium that's floating around in your blood because it's come out of your bones, that can also lead to renal calculi or kidney stones, okay? Most kidney stones are made up of calcium. So we want to increase their fluid, okay, as much as we can. Make sure that if you have someone who's bedbound, if they're incontinent, that we are performing peri-care correctly so that they don't get a UTI. As far as the skin goes, when we are not moving, we worry about pressure ulcers. This happens when the oxygens and nutrients to an area have been interrupted. Most commonly, we see this start at bony prominences, so places like your elbow. If you're really skinny, your backbone, your bottom, that's probably the most common to get one on your coccyx. And the longer we have that pressure applied, the greater the risk of skin breakdown. Now, an older adult can get skin breakdown within about 3 hours because they have very, very thin skin. So to prevent it, we constantly want to be reposition them at least every 2 hours, at the very least. Use pillows to support them, pillow between their legs, and put their arm on a pillow. And we might put them on a pressure redistribution mattress, maybe one that kind of airs up on one side, then it airs on the other, and so it just kind of gently rotates them. Moisturize their skin. Again, make sure they're eating plenty and drinking plenty. That's going to help their skin so much. And make sure that we are not letting them lay in urine or feces, or maybe they've spilt water in their bed. We don't want them to be laying on that. This kind of shows the correct position that you need to be in whenever you're laying down. We don't want the head up too far. We want to make sure that their spine is aligned with their hips and legs. Now I'm just going to show you really quickly some of these different pressure injuries that may occur if somebody is immobile. We're going to talk about these later in the class, but I just want to give you an example of what they look like. So for stage 1, their skin is still intact, but it's a non-blanchable redness. And what I mean by that is if I touch it and let go, it is not going to turn white like normally our skin does. Stage 2 is kind of what we see here at the top picture. We have an open area. We can see a pink wound bed. Maybe it has a blister that's popped. That's stage 2. Stage 3 goes down into the full thickness skin loss. You'll probably see some fat tissue there, some granulation tissue. You may even see some eschar, which is dead tissue. And you can see that in the bottom picture there. Stage 4 is the worst there is. It's full thickness loss of that skin. You can go down, you can open that wound, it goes deep. You can usually see bone. Again, you can have some eschar there. You might have some tunneling, and again, we'll talk about all of these things in skin integrity, but I just want you to be aware of it. We also have things like unstageable pressure injury, where we can't tell how deep it is because it's got a lot of eschar or dead tissue on top of it, and we don't want to peel that back and open up that wound again. So we don't mess with it. We just say it's unstageable. And then there's a deep tissue pressure injury, and this is where we see like a dark red, purple, dark coloration. It's non-blanchable again. It may be something like a blood-filled blister, or it may be just a dark wound bed. Again, we don't stage these. We don't try to open them up or anything like that because we don't want to cause more harm to our client. Immobilization can also affect their emotional status. So think about that. If I'm immobile, it's going to affect my daily routine. We want them to participate as much as possible within their care, but sometimes they just don't feel like participating in their care. So as we're taking care of somebody, let's remember they might be upset because they're immobile. They might be scared because something new is happening. And I always say this, think about if you had to have someone give you a shower, how humiliating would that be for you? How embarrassed would you be about that? And we as healthcare workers, we get used to doing this thing, so it's no big deal to us. But for that patient, it may be their very first time having to be bathed by someone. So please be very considerate and remember those types of things. Make sure you prepare for their privacy and things like that. They'll also have like some sensory alterations. We see this especially in the ICU. The lights in the ICU are on 24/7, and so sometimes they'll get their days and nights mixed up, and so it makes it difficult for them to get the rest that they need. After a while of being immobile or being sick, it can certainly cause some sadness. And so we want to make sure that we're having them interact with others. We don't want them to sit in their room with the curtains drawn all day. We would like to open it up and give them some light into their room. So when we're doing our assessments, we're going to look at their functional status. So we have to find out what is their normal mobility status. We're going to do some range of motion on them. We want to ask them, does this hurt? Are you stiff here? Do you have swelling? Do you have pain? Look to make sure that they have equal movements bilaterally. We can look at their gait and we'll say, are you balanced? Are you able to walk by yourself? What's your posture look like? Are you grabbing onto things? And then when we talk about activity tolerance, this is the type and amount of activity that that person is able to perform, okay? We have to know this when we're planning our care because we have to know, can our client get up and walk to the bathroom by themselves? While they're walking or while they're moving around, notice, are they short of breath? Are they having chest pains? Do they look like they're tiring out? We can also check their vital signs before, during, and after movement so that we can see what changes that there might be, if there's any significant changes. Again, other things that we look at when we're assessing them, we want to make sure that they are not losing weight. We want to make sure they don't have muscles that are atrophying. We want to monitor their intake and output for dehydration. So we want to look, do our I's and O's match? Am I taking in about as much as I'm putting out? We can look at some lab values and see if there's any abnormalities in their prealbumin. Look at their food intake. Do we need to give them extra protein? Are they even eating enough? Respiratory, we're going to look at their wall movement of their chest. We're going to auscultate the lungs. We're going to listen at the bases. We're going to listen front and back. Are there any areas where they're having decreased breath sounds, any crackles, any wheezes? From a cardiovascular standpoint, we're going to monitor for orthostatic hypotension. Look at their peripheral pulses. Reach down there and feel around their ankles and feel those pulses. Are they strong? Are they equal? Does that tell us we're getting enough blood to the extremities? Is there any edema? That's going to say, hey, something's wrong with the heart if I'm not getting rid of all this fluid. On their legs, even on their arms, look for DVT, a deep vein thrombosis. See if it's warm. Is one leg bigger than the other? Is it red? Musculoskeletal wise, we're going to look at their muscle strength and tone. We're going to look at their range of motion. Have they developed any contractures? Have them push against your hands with their feet or squeeze your hands with their hands to make sure that they are continuing to have the strength that they need. Skin, we want to make sure that we assess that frequently. We want to assess it on admission. We also want to assess it throughout the stay with us. And again, it's not something you have to go and say, okay, strip down, let me see your skin. As you're giving them a bath or as you're doing their vital signs, that's a good time for you to check them over and see what they look like. Their elimination system, we want to, again, look at that intake and output, make sure they're measuring pretty close to the same. Bowel sounds, do they have positive bowel sounds? Are they incontinent? Are they continent? Are they going to the bathroom enough? When was the last time they had a bowel movement? Psychosocial, we want to look at their emotional state. Look at their behavior. Are they acting like they're depressed? Ask them if they're sleeping well. Are they bored? Are they anxious? Is there something that you could do for yourself that you're not willing to do? And you may see a change in these behaviors on a daily basis. And then developmentally, we want to look at how that immobility affects their normal development. So are they still independent? What about safety issues? Since their hospitalization, are they still safe getting up and ambulating by themselves? Just take a minute and kind of look at this screen. When we're talking about range of motion, you're going to see these types of words used. So flexion would be like bending, and extension, I think of extending out my arms. ABD, abduction, is moving away. Adduction, I think of that as ADD, adding, like plus two, putting it together. Pronation is your hands down, like you're pouring something out. And supination is your hands up, like a soup bowl. Circumduction is moving around in a circular motion. So just kind of familiarize yourself with some of those terms. Here are some assistive devices, and we want to make sure that we have educated the client on how to use these properly. We have some canes up there. We have a regular cane, and then we have the four-legged cane. We want them to carry their cane on their strong side, okay? There's some walkers, a couple different types of walkers. We want them to walk into the walker. We want them to use it appropriately. We should be using gait belts anytime we're transferring our clients. We want to make sure we're using a gait belt. And of course, crutches. We don't want them leaning on their crutches. We don't want them putting their weight from their armpits on their crutches, because that can cause damage to those arteries underneath there, the nerves that are under there, the brachial nerves. So they have to be fitted appropriately for person to person. All right, so let's look next at a few different questions. You can pause the video and you can read this to yourself. Again, we've got someone who's immobile. And your answer is going to be D. We do want to do some skin assessments at least once a shift. Next question. Where do we want our balance? Where's our body mass distributed? And that's going to be C. That's what we call our center of gravity. These are some hazards of immobility that we talked about. So when we have clients, especially elders who are immobilized or in the hospital, what do we want for them? Well, E, all the above. We worry about all those things happening. And the most important strategy in minimizing the risk of immobility is avoid hospitalization. A, that's right. So if we can avoid them getting sick, if we can avoid them needing to be in the hospital, that will help to keep them up and moving. Is this true or false? This is false. We want to do as minimally possible for them, letting them do as much as possible for themselves so that they don't get weak, get too weak. And the last one. And again, it's all of the above. If we think we can benefit, if we like what we're doing, if we can do it, if we have the means to get to it, if we can fit it into our schedule, all of those things are likely to keep us physically active.